Good morning, everyone. And I'd like to thank everyone, the organizers, for the invitation to speak today. And if I teach you anything today, it's called the Loes score. Dan pronounces his name Les. I know it looks like Loes, but it's pronounced Les, and we're going to respect that. Okay, I changed the focus of my talk just a little bit. I figured I'd cover what is MRI, what does normal brain imaging look like, why it's important in X-linked adrenal leukodystrophy, our sort of rationale for monitoring, how the images are evaluated. I am going to discuss contrast or no contrast. I was going to cover what age to start and stop, and then now what happens when someone sees something, what next? Because I think that's what really, we get the most emails about, someone saw something, what am I going to do? What's the next steps? Okay, so what is MRI? It's an engineering marvel. It's a non-invasive imaging technique that produces three-dimensional detailed anatomic images. You can pretty much MRI anything on our bodies. It's really based on very sophisticated technology that uses a magnet to detect the changes in the direction of rotational axis of protons, and most of the protons in our body are water. So it's really measuring, to some extent, the spinning of water, and it sends a pulse, and then it receives that pulse, and then it interprets that in a billion different directions, and it gives us beautiful images. And we're going to see some of those images. It's really changed. It really has changed, I would say, practice of medicine, not only in neurology, but across multiple disciplines. What are the risks? It's a big magnet. So if we brought this big magnet into this room, everything that's metal would be sucked towards it. And there's some really cute memes on the internet of pictures of things getting sucked into it, but it's also incredibly dangerous. So we want nothing that is that is ferrous to come in close contact with that magnet. Things get implanted into our bodies, not just hips as I age, but things like pacemakers, pumps, things like that. Those things can also be a risk in the magnet. The magnet also is incredibly noisy in its acquisition, and we'll talk about some of that. And you need to hold still. These are sort of the things that are the basics of MRI. Dr. Fatimi spoke about sort of the basic images, and we're going to just touch on some of them. We really want what we refer to as a sagittal T1 weighted, which is kind of this image. We also want axial flare and T2 weighted images, which look like this. Hold on one more second. Do we get them? There we go. And what characterizes them? Well, the thing about T2 weighted images is really looking at myelin very well. And what it's looking at, I'm just going to go point, is that the myelin is that these dark bands, that's the myelinated white matter fibers. Let's see, do I have a pointer in this? No, I guess I don't. And looking at them all across, we have the T1 weighted where the ventricles are dark. We have the T2 weighted where the ventricles are bright signaled, and then the flare where we suppress that water signal. But we're going to be looking at these myelinated fiber bands. And these are what become affected in the MRI. We've seen some of that. Initially, we used to talk about the posterior, or the bottom here of the slide. 85% were parietal occipital, 15% were frontal, and this garland of enhancement. And this is how individuals used to come to attention. And we saw a slide yesterday on the Cheshire Cat, and so I'm doing my homage to Charles Dickens today. Why do I want to see that? Well, we want to avoid that. We want to provide hope. And this is what the ALD MRI looks like in an asymptomatic individual. This is actually a boy with ALD. His MRI is completely normal at this stage. There is no lesional involvement. But this is what we've seen examples on in the previous talk, and we'll see some examples in this talk. what the early cerebral disease looks like. And there's the characteristic arrows that kind of highlight what I want you to look at. Early changes on MRI are characteristic of limited disease. It may or may not have contrast enhancement. I'm not going to really talk about Dr. Malik's work in terms of the development, but at this stage, the exam is completely normal. So early on in my career, I would get messages from pediatric neurologists saying, oh, we don't need to do an MRI. His exam is normal. It's like, that's exactly why we need to do an MRI. I don't care that his exam is normal. I don't care that his neuropsych is normal. This is the stage I want to see any changes occurring. And you'll probably see this slide several times because we didn't coordinate what we're going to talk about. So we're all going to use the same slides. This is Dr. Malik's work with Keith Van Haren, Anna Torrey, and others, and it really shows that the peak incidence of early cerebral ALD was about 6.4 years. And we had shown that years before with some other data in terms of when boys presented, but this is the modern compilation of this data. And again, I would emphasize the ranges here. So we see individuals presenting anywhere from 2 to approximately 12 and a half. And so that's what we're going to be focusing on. It's sort of statistics, but it's at the same time, it's what we're trying to hone in on. And this is just, once again, time from enhancement to treatment. We do pretty well in a product. We get people there to transplant in about 4 months. Okay. And then speaking of transplant, that's where we come into the scoring method for brain MRI. And there's 2 individuals on this slide. Dan Loes at the top. I knew him when his hair was dark, but mine was blonde. And the individual lower was Bill Crivet. And I'm looking around this room, and I'm probably the only person who ever met Bill Crivet. Bill Crivet was the chief of pediatrics at the University of Minnesota, but he was also the chief of their bone marrow transplant program. And Bill, to put it politely, was a force of nature. He cared very much about his patients, getting them to transplant. But the apocryphal story is that Dan was working there as a junior faculty, and Bill would come in, every time there was a boy there getting transplant, go, isn't this, holding up film. And that's exactly how old this is. We used to have these images on film. And Bill would come in and go, isn't this better? And Dan got tired of this, and he decided that he needed to come up with some system to score this so that he had an objective way of looking at the MRIs. And he came up with this system, which is sometimes referred to as the Loes system or the MRI severity score. And so it catalogs with points what's involved. So the parietal occipital white matter, maximum of 4, frontal white matter, maximum of 4, and we look at the periventricular, central, subcortical, and then local atrophy. Same thing with corpus callosum. Now, I'm throwing out words here that you would go, I don't know what that part of the brain. That's why some of this should be left in the hands of sometimes people who know. Okay. But I'm going to highlight here, without the arrow, that the splenium of the corpus callosum here is involved. That's that bright signal there in the back. So what would my score be? Volunteers from the audience? It's a 1. I'm going to give it a 1, just based upon that's what it gives me that vibe. Now, the other thing you need to be aware of is that MRI is just not one image. We scroll through varying planes of these images, and so this is a sort of a dynamic process. Okay, this MRI is much more involved. It's now involved parts of the corpus callosum, the parietal occipital white matter, parts of the internal posterior limb of the internal capsule. all in all, this MRI is moving on to a score of 5, 6, 7. I'm making up a number, but that's just essentially what we're seeing. Okay. Now, there are some things that don't get scored on the MRI. You see these little, and I put boxes around them. These are normal variants, and these are not getting scored. But then you need to be somewhat familiar with ALD to recognize that. Now, we heard in the last talk a question about how do we deal with the myelination. So what is myelination? Myelination is the formation of myelin over the spectrum of development. And there was a very cute toddler in here a little while ago. But if you notice that a child doesn't walk and do all the things, and we're kind of built to thinking that we learn to walk. Well, we actually don't learn to walk. We develop myelin to walk. And so we're programmed to walk. I'm programmed to make fine movements. These kinds of things are occurring on a natural time scale. And so we can look at MRIs from very early on, and that myelin is underdeveloped. And it develops over the course of months to where a 12-month-old, I can see this myelin, and I'm sorry for the people on the line, but this myelin is now getting dark. And now this myelin is getting darker here. So that myelination is occurring over time. But prior to that, that myelination is not as dark on those images. And so that can be kind of tricky in terms of what we're seeing. And that's kind of what we're seeing here, is what we're seeing, that haziness out there is what we refer to as terminal myelination. And so you need to take that into account. When I look at an MRI from an ALD individual who's 1.5 years of age, and I'm seeing that, and they're going, is that disease? I actually focus first on what am I seeing in the splenium, which is the back corpus callosum. Once again, this band here, or the front of the brain, and I'm looking at those things to determine whether I see a lesion where I think I may see a lesion, where I should be seeing a lesion. It's pattern recognition for many of us. Okay, so we've heard recommended monitoring. This is what New York came up with a number of years ago. MRI starting at 12 to 18 months. Yes, part of it is just making certain that we engage with the patient. We start looking at MRIs around 12 to 18 months. And that was actually an issue in New York when, because of, I would have discussions with the New York centers, and I apparently didn't know my disease, and so they wanted to start screening earlier than that because I didn't know everything that was going to occur at ALD. So they started screening at 6 months, and that led to concerns with early myelination. We then do yearly MRIs till 36 months, and then every 6 months till age 10, 11, or 12. It's squishy. I think the official recommendation is 12 because there's those outliers. You know, I encourage individuals after age 5 to 6 to get it without sedation. We'll talk about sedation in a bit, and not recommending routine contrast. And then yearly after that, although that's up for discussion. Why sedation? Well, the image on the right is what happens when you move. You gotta be still. And I can get, Miranda's son is the outlier. Jack glided still because they couldn't get the sedation to him, and he wanted to get moving up. Mom wanted to go home, and he did it like 3.5 or 3. 3. The youngest I had gotten any individual through before that was up to about 4. That was a lot of coaching on my part. But usually around 5 or 6, they've got the they're in school, they've either done daycare, they know to sit. And if you tell them, you gotta hold still and get through this, they will get through this. Gadolinium contrast. Well, it does show active cerebral disease. But it has it's generally well tolerated. It needs an IV. It causes mild temporary side effects like coldness. Some people feel a little numbness when they get it. Allergic reactions have been reported. They're really quite rare, but but there's really increasing concerns about if you have renal disease, which most of our boys do not have, and simultaneous diabetes. And then there's been retained gadolinium for persistent tissues, and there's sort of a theoretical out there that maybe this causes some harm. The issues are, if it's not done and a lesion is seen, you're gonna have to bring them back, and that's not usually a problem in the US, but as Dr. Fatimi indicated, some people live very far away from us, and so we have to then make those arrangements. And if sedation wasn't used and you're now going to place an IV catheter, you're probably going to lose the cooperation of that 6-year-old. And so there are pluses and minuses, including GAD and routinely. Okay, this is the question we all get asked most of. Some radiologists saw something, now what? If questionable, I think, again, I'm gonna walk, I'll do the room. I'll walk over here. I don't know if you can see this. Is that a lesion? Is that something we sometimes refer to as volume averaging? Maybe that's the only section I'm seeing it on. We would typically recommend rescanning in 3 months with contrast. That would be the indication. It's like, was he gonna hold still? If he's not, we're gonna do this. We're gonna make sure we get the best images we can. That would be generally my recommendation. If it's still kind of questionable, confer with a center with experience. I review MRIs all the time. The group in Minnesota will review your MRIs, or maybe go meet with a center and let them review your MRI. These are my recommendations. Okay, I'm gonna stop there. There actually is a stupid question day. It's in September. And I know it's not today, but you can ask any question at all, and it's going to be an intelligent, well-formed question. Go ahead.
Great. Since you said stupid question, I thought I had to start.
He has to start.
That was beautiful. And so the theme I hear in both the talks, right, is obviously collectively we've learned so much over the years about lesion evolution, and what we did with Dr. Moser in its day has probably changed slightly because we're seeing patients earlier. But I think the big question for me recently, or in recent years, is, are really all lesions the same? And are we, using this term in ways that maybe we shouldn't? And you always showed splenium lesions, which in general sort of maybe follow a certain pattern. Corticospinal tract lesions get trickier, right?
And, I agree, and I'm not sure they're in the same bucket as splenial lesions.
So I guess my stupid question is, how would you think about the nature of different locations in terms of follow-up? And if you saw after 3 months, no contrast, how do you go on? And we struggle with this with every scan, and we sometimes start to say, okay, we're not seeing anything, there's still no contrast, maybe we'll go to 6 months. And then there's a question, how often do we want to see something that's on the edge and unclear? And maybe it's better to wait till something is clear, right?
I think Dr. Eichler is bringing up some wonderful points that are probably not solvable from a speaker on the podium. Because every single one of those becomes a nuanced individual decision. And my take generally has been when I see a lesion that I think is out of the ordinary, say a corticospinal tract lesion in a 9-year-old, I'm of the opinion I can probably wait. However, I do offer the option of moving ahead in a traditional way to a bone marrow transplant. And so it's a conversation.
For children that are post stem cell transplant or gene therapy, most of us, our fear is that this thing's going to start up again. Can you talk a little bit about that and about what the current recommendations are for monitoring post-intervention?
So the actual evidence that something is going to start up again, I'm going to go out on a limb here. I've never seen it. Now there may be progression, sort of because of momentum, but I have never seen true startup again, new active disease, if it truly has been shut down. It is, when I was in Minnesota, we would continue to monitor individuals as long as they wanted, yearly. Now, lots of people slipped away, and so I'm not certain. And then it always brought up the case, what the heck were we going to do if we saw something reactivate? We never did. And I've seen the individuals who are probably the longest out from transplant in this country. But it's an unsettled question. Keith?
You might distinguish gene therapy transplant and allo.
Yeah. So allo, I've not seen, and I know there's a flicker of contrast in the gene therapy patients, but at the same time, I'm not certain I've seen true really reignition of disease. Florian, you want to speak?
No, I think it's the same conundrum, right? Are we using the right terms?
Yeah.
Sorry.
He's going to get his steps in.
Yeah. So if I can just, as I try to think about what's happening in the field and what terms we use, and it's very important to give guidance and be clear so that everybody's doing the same thing. And I get that, but sometimes I worry what we're missing, and maybe the one thing that we don't talk about enough is time, and how much time has passed. And I do think sometimes maybe that's a bigger factor, like when a lesion is indolent and it's been going on for years, and maybe contrast is not the same flicker as a garland of contrast enhancement, right? And so these are, I think, things that would be nice if, we're going to see more and more of this as we do more newborn screening, and there's going to be much more disease that looks different than what we saw before, right? Sorry, not to...
No. Anything in the chat? Good. I solved the world's problems.